Okay, I make it 4 o'clock now, so we will start the webinar. Welcome everybody to today's webinar, which is about imaging. Just trying to move my slide on. That's it. A few housekeeping points. There's a Q&A box. You can put your questions in there. We are going to be quite tight for time, so I'm not sure how many questions we'll get through, but we'll get through as many as we can. You can use the chat box for general comments. After the webinar, you'll be sent details of how to watch the recording, and it'll be on the website as well. And you'll get certificates of attendance next week. We've got a feedback survey, so please fill that in so that we know how you got on. Just a couple of slides about the RCPsych Gatsby Wellcome Neuroscience project, which I hope that you've heard of. A lot of you will have heard me speaking about it. This was originally a 2-year initiative led by the college, and it was about modernising the neuroscience that we teach to trainees. When we started, the things that we were teaching were really a bit outdated. So the first 2 years we spent looking at that and updating the syllabus for paper A. We had very generous support from the Gatsby Foundation and the Wellcome Trust, and it was based on an American experience. The project was extended. At the end of the 2 years, we'd updated the syllabus for paper A, but we got another 3 years. And now we're really focusing on embedding neuroscience in psychiatry and working to raise the profile of neuroscience. Some of the things that we've done, we've run lots of events, we run talks, brain camps. We've been setting up networks where we connect neuroscientists with psychiatrists. We have other resources, e-learning, and we run an annual conference. And there's the link to the part on the college website that will tell you what the project is doing. So why neuroimaging? Why have we chosen that for today's webinar? Well, the use varies between clinicians. Some people use imaging a lot more than others. Structural imaging is used quite a lot to exclude degenerative disorders or tumours. And functional imaging for dementia is under development. I'm an old age psychiatrist. I work in dementia, and functional imaging is going to actually start changing how we practice fairly soon. It's used very widely in research, and it's something that psychiatrists really want to understand. When we run our brain camps, this is the most requested topic, and this is actually the biggest webinar that we've ever held. We've had the most number of people sign up that we've ever had. So we are going to extend this a bit, and at some point we'll be having a half-day event where we talk in a bit more detail than we can get through today. So look on our website for details of that. And of course, it's in our syllabus, it's in our paper A syllabus. It's important that people understand the neuroscience and the imaging. So Matt Wall, who is our speaker today, he initially trained in experimental psychology. He's worked in neuroscience. He currently works at a clinical imaging centre based in London, and he has honorary appointments at Imperial and at UCL. And I'm very grateful, Matt, for you coming to speak to us today. I'll now hand over to you.
Thank you very much, Wendy. That was great. Right, I've got to share my screen, haven't I? There we go. How's that? Is that good?
Yeah, that's good.
Right. So, yeah, so I'm started off with a little slide about me. So importantly, I'm not a clinician. I work with a lot of psychiatrists and other doctors, but I'm not a clinician myself. I'm also not really an academic, although I do a fairly convincing impression of one. I work for this private company in Vicro. We do contract research mostly for pharmaceutical companies. And but I also do a lot of academic work with people at Imperial and UCL, and I work on an Imperial campus in Hammersmith Hospital. And I work on a lot of different things, but the common thread through them all, through my whole career really, has been functional MRI. That's my specialty. So I'm going to talk today about neuroimaging. Brain scanners, as everyone knows, the point of a brain scanner is to generate high impact scientific publications, which in turn generates successful careers for the people that use them. But you may also know that they can also be used to generate pictures of the inside of the body of various kinds, and that's what I'm going to be talking about today. So there's lots of different kind of brain imaging technologies, roughly in order of age. There's EEG, so people have been sticking electrodes on their heads since the 19th century, really, and looking at EEG data. In the 60s, 70s, along came computed tomography, which is essentially a fancy X-ray, a fancy 3D X-ray. Out of that also came single photon emission computed tomography, or SPECT. Then in the 80s, PET was developed, positron emission tomography. And in, well, late 80s, early 90s, MRI became quite popular. And the latest one really is magnetoencephalography, which is kind of similar to EEG, the very oldest one, in that it measures electrical fields, but it measures the magnetic properties of those fields. So what I'm going to be talking about today are PET and MRI. They're probably the most common, probably also the most useful, certainly the most common clinically. And probably the reason for that is that they have a kind of, they sit at a useful point in terms of spatial and temporal resolution. So functional MRI sits about there and PET sits about there. So on the vertical axis here, we have size from a single synapse up to the whole brain. And here we have time from milliseconds to hours and days. And, you know, with neither of these techniques, you're not going to be able to get an image of a single synapse or a single neuron. These work at the level of pretty much the whole brain. Although they, you know, you can do some high resolution stuff and look at cortical columns and things like that. And they also work over timescales. You're not going to be able to do anything super fast with them, like EEG. You can't get millisecond resolution data, but they work over seconds to minutes in functional MRI, and, you know, hours to days in PET. And it turns out actually this kind of level of explanation, this level of analysis, turns out to be quite useful in terms of what it can provide. So they provide kind of large scale systems level information about the brain, nothing very fine grained, but that can be a useful level of analysis. Of course, there are lots of others that are also useful too. So PET provides very precise in terms of the ability to quantitate it. So it's a very quantitative technique, provides very precise information about neurochemistry. So about a particular compound or a particular brain receptor. If you're doing it in the brain, you can do it in other parts of the body, of course. One issue with PET is it's quite invasive. So first of all, you have to inject your patient with a radioactive tracer. For a lot of PET studies, you also need to have an arterial line in to do continuous blood sampling. Anyone who's ever had an arterial line will tell you that it's not a lot of fun. The temporal and spatial resolution is fairly poor. So it has a temporal resolution of, you know, minutes to hours, and the spatial resolution of, you know, maybe 0.5 centimeter to 1 centimeter. But the sensitivity is extremely high. So modern PET scanners are incredibly sensitive in terms of the amount of radiation they can detect. So you can detect concentrations of radio tracers in the kind of nanomolar range, even down to the picomolar range. How you do PET? First of all, you need some radioactive isotopes, and these are typically generated in a machine called a cyclotron, which looks like this. And this is essentially a mini particle accelerator that smashes atoms together and produces isotopes. Then you need to do some kind of chemistry with those isotopes. So you might have a molecule that you're interested in. You need to take one standard carbon atom, one carbon-12 atom off that molecule, replace it with, say, a carbon-11 atom that you've generated in your cyclotron, which is an unstable isotope of carbon. But the problem is, this is all radioactive. You can't really touch it. So you have to do all this chemistry inside these lead-lined boxes that we call hot cells, hot because they're radioactive. And inside those boxes are all this complicated kind of robotic chemistry equipment, because you can't touch any of this while you're doing these chemical reactions. So it all has to proceed automatically. Then you safety check it, of course. You do some quality control. You inject it into the patient and you stick the patient in a PET scanner and you get some nice looking brain images from them. And it works like this. So you have your unstable isotope, a proton in there decays to a neutron in the nucleus of the atom. That emits a positron and a neutrino. There's the neutrino flying off to go through the Earth. There's the positron. Now, any Star Trek fans will know that a positron is a particle of antimatter. And what happens when you put antimatter and matter together is that they annihilate each other. So the positron wiggles around a bit, finds an electron. They annihilate each other. And when they do that, they give off a little burst of radiation, gamma radiation, and it always emits two gamma particles at 180 degrees to each other precisely. So what you have in the PET scanner, you have all these little annihilation events happening inside the body, with all of these gamma rays coming out at 180 degrees from each other. And you have a ring of gamma detectors around the patient. And when the gamma detector on one side detects a gamma ray at the same time as another one on that side, you've got an event, and you can pinpoint where in the body that happens based on the different timing of these two detections. And in that way, you can build up an image of the radiation in the subject. So the simplest kind of example of PET is using FDG. So FDG is fluid deoxyglucose, which has had an unstable fluorine atom, a fluorine 18 atom added to it. And this is the most routine clinical use of PET. So it's used a lot in cancer, because fluid deoxyglucose is a sugar. It tends to accumulate in the most metabolically active tissues. Cancer cells, very metabolically active, tumors, that kind of thing. They're growing very fast. They're consuming a lot of resources. They go all, nice sugar, yum, yum. So we can see here examples in breast cancer. This unfortunate patient has a nice carcinoma in the lung here, and this brain tumor on the right. So they show up very nicely with FDG PET. You can also use FDG PET to look at the brain, because the brain is also very metabolically active. It's about 5% of the body weight usually, but it consumes about 20% of the oxygen that we intake. So it's very metabolically active compared to other body tissues. FDG PET can be useful for differentiating dementia subtypes. So we can see a control subject here, their brain metabolism looks fairly even. With Alzheimer's disease, you tend to get drops in brain metabolism in particularly the temporal lobes. With frontotemporal dementia, it tends to be more in the front. With Lewy body dementia, you tend to get these specific kind of hotspots. Another example here, control in the middle, and an Alzheimer's patient at the bottom there. Probably the most of the PET studies that we do, where I work, are related to drug development. And PET is extremely useful, can be extremely useful in drug development, particularly for psychiatric drugs. And there are basically two kinds of studies that you can do there. First one being biodistribution studies. So this is fairly simple. So you have a molecule that you're interested in, i.e. your drug, your new drug candidate that you want to test. So you simply radioactively label that drug. You take one carbon atom off, you stick on your radioactive carbon-11 isotope, and you put it into the body, and you see where it goes. So this is simple but very important, because for psychiatric drugs, one big issue is in drug development is, does it get past the blood-brain barrier? The blood-brain barrier is fairly impermeable to a lot of things. Some things get through, some things don't, and it's not always easy to predict what exactly is going to get through and what's not. There are also some species differences here in the permeability of the blood-brain barrier for particular compounds. So you can see in the rat, very little gets through of this particular compound. In the pig, quite a lot gets through, and in the human, a kind of medium amount gets through. So you can do some animal work, preclinical work, looking at the blood-brain barrier, but there's no substitute really for testing it out in humans. And you can also compare the permeability of different compounds. So here we've got two examples in these animations here, compound A, compound B. This is a dynamic PET scan over time. So as you can see over time, compound A is accumulating very nicely in the brain, compound B, not so much. So the implication here is that the blood-brain barrier is much less permeable to compound B, and that's probably not such a great drug candidate to take forward for further testing. Occupancy studies are a little bit more complicated, and they require a suitable, what's called a PET ligand, which is a radio tracer. So for a good PET ligand candidate, it has to have certain characteristics. First of all, of course, it's got to penetrate the blood-brain barrier. Secondly, ideally, it's got to have quite a specific pharmacology, meaning that it's got to bind to a specific receptor or receptor subtype, or a specific target of some kind, specific protein, so on. You know, very non-specific, a drug that has very non-specific binding is not going to make a good PET radio tracer. It's got to have roughly the right pharmacokinetic profile as well. So ideally, you want something that peaks and accumulates in about an hour and then starts to wash out. If it takes, you know, 4 hours to reach a peak in the brain, you don't want to have your subject, your patient, in the scanner for 4 hours or 6 hours so you can see the washout. And also, ideally, it's got to be a relatively simple molecule that's easy to synthesize and easy to work with when you do the chemistry. So some examples of some of the compounds that we use. There's about 100 that have been developed, I think probably more than 100. Mostly they tend to use carbon-11 or fluorine-18, though there are some more exotic isotopes that people use. But given that we know there's probably thousands of different proteins and receptors in the brain, about 100 PET ligands is, you know, we're still just scratching the surface, but, you know, we do what we can. So we've got things like carfentanil, which is a mu-opioid agonist. That's specific for mu-opioid receptors. We've got F-dopa, which is a marker of dopamine synthesis, PHNO, which is another dopamine ligand that specifically binds to D2 and D3 receptors. Various others. The couple at the bottom here are interesting. Beta amyloid and tau. These are two proteins that are thought to be very important in the development of Alzheimer's. There are quite a few different drugs currently under development at various stages, which are designed to clear beta amyloid and tau out from the brain in the hope that that will improve Alzheimer's. So there's a lot of work in the last 10, 15 years looking at beta amyloid and tau in Alzheimer's particularly. So this is how occupancy studies work. You do 2 PET scans. You do a baseline scan with your radioligand, your PET tracer. So in this case, let's say it's a dopamine agonist of some kind. So you have the radioligand here in red that binds to these blue dopamine receptors, and you get a nice strong signal in areas of the brain where there's a lot of dopaminergic receptors, like the striatum and the brainstem. Then usually later on the same day, sometimes the next day, you do a second PET scan where you administer the same PET tracer, same radioligand, but you also administer the drug beforehand. And that can be an oral dose, it can be a infusion, it can be whatever you want. So what happens here is if your drug is also binding to the same receptors, we have a kind of competitive situation here where the drug is binding to some receptors and not leaving as much space for the ligand to bind. And that means you get a much reduced signal. And the amount of reduction of that signal can tell you some interesting things about your drug. Basically, it tells you the affinity of your drug, or how good your drug is at binding to dopamine receptors. And it tells you the amount of occupancy that you get, because the radio tracer you use has been well characterized, well quantified. You know what to get, what you're going to get with this. The amount of reduction you get tells you about the potency of your drug. And you can do some while you're doing this, you can do continuous blood sampling, looking at the levels of drug in the blood, and you can relate the proportion of receptors that you have occupied by the drug to the plasma concentration in the blood. And that can tell you some interesting things about dosing. So if you know you need to hit, as with most dopaminergic drugs, say most antipsychotics, you need to hit about 65% receptor occupancy before you get any therapeutic effect. So by knowing the level of occupancy you're getting and knowing the plasma concentrations in the blood, that can tell you what's a good dose to administer in other studies or in your patients. And of course, the occupancy is both dose and time dependent. So obviously you get higher occupancy with higher doses, but then there's a time factor as well. So it's going to peak and then fall off. So you can go from this PET data about occupancy and develop a model of how your drug is going to respond in a kind of multiple dosing situation. If you want to know, okay, we need to give, you might be able to derive something like, we need to give 25 milligrams of this 3 times a day in order to maintain a certain level of occupancy at the receptors in the brain. So that's useful information. Moving on to MRI. So an MRI scanner, it looks quite a lot like a PET scanner. It's both big donut things. But here we go, MRI scanner. They're very different on the inside. So it's a huge superconducting magnet in an MRI scanner. The ones I use are 3 Tesla. Normally, hospital ones tend to be 1.5 Tesla. But a 3 Tesla one is about 60,000 times the Earth's magnetic field. They are very, very strong magnets. They're completely safe as long as there's no metal around. If people do stupid things and wheel things into the MRI room that shouldn't be wheeled in there, then suddenly they find them flying into the scanner. You can search for MRI safety on YouTube for lots of cool videos of things flying into MRI scanners. It's a very flexible imaging method. The PET guys hate it when I say this, but a PET scanner is a pretty dumb machine. So a lot of the clever stuff with PET happens in the chemistry labs beforehand. So if you can develop a great new PET ligand that's specific for a new type of receptor in the brain that nobody's discovered before, that's fantastic. Once you put the patient into the PET scanner, it's pretty boring. The patient lies there for an hour and a half doing nothing. You just collect lots of data and you basically hit a button and the PET scanner just does it. With an MRI, in an MRI experiment, typically you might be getting multiple different types of data from the same subject. So you can get functional data about brain activity. You can get various kinds of anatomical images. You can look at the white matter of the brain using diffusion. You can look at spectroscopy, different levels of metabolites in the brain. I mean, you can even image other squishy bits of the body if you really must. I mean, I don't know why you'd want to, but people do. The problem is the signal to noise ratio is generally lower than PET, so it's not as sensitive. You normally need more data to be reliable, more subjects, that kind of thing. It's not as sensitive, but it is a lot more flexible. Here's my attempt at doing the whole of MRI physics in one slide. So this is how it works. You have protons in the body, they're mostly in hydrogen atoms in water molecules because your body has a lot of water in. And when you put an object in the MRI scanner, like a human body, all the protons in it will line up with the direction, the main axis of the magnetic field. And they'll keep spinning like they do. What we do then is we apply a radio frequency pulse at right angles to the main magnetic field, so going across in this direction. And what that does to some of the protons is it flips them from their up-down orientation to a left-right orientation. And then when the pulse gets turned off, it's a very quick pulse. So after the pulse, they flip back to their original orientation in line with the magnetic field. And as they flip back, they give off a tiny little burst of energy. And this is broadband energy. It's light, it's heat, it's microwaves, and it's radio waves. And it turns out you can actually listen for that signal and record that radio signal that you get back. So we call that the RF echo, if you like, because it's, you apply a radio frequency and you get this kind of echo back. So that's the basis of the signal. It gets a little bit more complicated than that because you need to know where the signals are coming from. So to do that, we apply things called gradient fields, and these are other magnetic fields which are applied using electromagnets in the scanner, so we can turn them on and off, and they get turned on and off very fast. So by applying a magnetic field which has a gradient, so it's stronger at one end of the object than the other, that changes the signals that you get from the protons flipping in a systematic way. So you know that they're going to be slow at the end and fast at the top. And in that way, we can pinpoint exactly where in the object we're getting these signals from. And finally, we get different signals from different types of body tissues. So you might get a different signal from the white matter, from the CSF, and from the gray matter. And that allows us to build up images of different tissue types. And we do all this radio frequency stuff generally with a head coil, which fits over the patient's head like this. And there's lots of other coils you can get for different body parts as well, of course. So probably the most common clinical type of scan is an anatomical image. There's lots of different types of anatomical MRI. This is all my brain on the top row here. It's not actually that color. I just applied those colors afterwards. There's different types of anatomy. There's lots of different types. These are three common ones. You can get different kinds of image which highlight different kinds of tissue. For instance, like flare images are really good in looking at lesions related to multiple sclerosis and things like that. T2 images show up certain certain brain issues better than T1, things like that. The more interesting one for me anyway is functional MRI. So this is a kind of adaptation of standard anatomical MRI. So instead of looking at the magnetic properties of different tissue types, you're actually looking at the magnetic properties of blood. And it turns out that hemoglobin is a useful molecule because hemoglobin has a nice iron atom at the center of it. That's, you know, we all know that's why blood is red. It's got iron in it. Well, there is an iron atom at the center of every hemoglobin molecule. And it also turns out that oxygenated and deoxygenated hemoglobin have slightly different magnetic properties. And what this means is it allows us to see areas of the brain that are more active than others. When an area of the brain becomes active, the neurons start firing strongly. It needs more resources. It needs more ATP and more oxygen to be delivered to it. And the vascular system of the brain reacts and dumps oxygenated hemoglobin in that spot, and we can see that change in the MRI scanner. So this is a kind of a dynamic measure, meaning it's extended over time. So rather than just taking a picture like the anatomical stuff on the previous slide, it's more like taking a movie over, you know, several minutes, maybe up to 10 or 20 minutes. So it kind of works like this. This is a little kind of toy experiment Oh, this is also my brain, I think, at the back here. Yeah. So here I am looking at a screen. You can see a nice, pretty visual pattern on the screen. When the visual pattern appears, my visual cortex in the back of the brain starts working harder, needing more energy, needing more resources, and lights up. And when the pattern goes off, my visual cortex quietens down again. And that effect is called, that effect of the vascular system dumping oxygen in particular spots that are more active, is called the BOLD effect, blood oxygen level dependent effect. One common type is called task fMRI. So this is basically when you have your subject doing something in the scanner. Could be, you know, watching a movie, looking at pictures, playing a little kind of cognitive game type thing, remembering stuff, reacting to stimuli. We can do, you know, we can do audio, visual, smell, pain, tactile, all kinds of stuff. And this relies on something called the method of subtraction to isolate effects. So this is data from one of my studies. This is actually data from a single subject. In this study, we were looking at a sex hormone, actually, the effects of a sex hormone. So we were interested in its effects on the brain's response to kind of romantic couple bonding type stimuli like this. So we showed people a bunch of pictures like this. What happens when you show people pictures is their visual cortex at the back of the brain lights up, because the visual cortex responds to pretty much anything visual. But you also see some nice reddy bits in the medial temporal lobes, in areas like the amygdala, these kind of areas that are normally thought of as kind of related to emotion at the front there. Then you have a control stimulus. So you also show them a bunch of really boring neutral pictures, like a mug, a book, a cup, a table, just boring everyday objects. And what happens there is that, of course, the visual cortex lights up as well, because the brain is seeing something. That will always happen, but you don't get the emotional response at the front there. So what we then do is we subtract this from this, and the visual cortex activation is basically the same. You subtract two things that are basically the same from each other, you end up with 0. So that goes away, mostly at the back there. And what you're left with is just the things that are different from the two images. You're left with just the emotional areas lighting up there. That's the general approach behind most kind of task fMRI studies. The other kind of fMRI study is resting state fMRI. And this, again, relates to the fact that the brain is metabolically very active, even when you're doing nothing. And it turns out that even when you're doing nothing, all of the bits of the brain that normally talk to each other remain talking to each other. They all coordinate their activity pretty much all the time. And you can break this down into different networks. The most famous ones are probably the default mode network or the executive network. But there's lots of others that have been found. So all the visual bits of the brain talk to each other all the time, even when your eyes are closed. All the auditory bits talk to each other all the time, even when you're not hearing anything, that kind of thing. And it turns out that defining these networks and looking at how the different nodes in the network relate to each other, and how the networks themselves relate between networks, can be quite a sensitive measure of various things like pathology or developmental effects, or even acute drug effects. So this is an example from my own work where we used this approach to look at the effects of 2 different types of cannabis. I'm not going to go into the details of this because I don't really have time, but we looked at a particular network called the default mode network. And we were looking at different cannabis with different levels of cannabinoids in. And we found that the most potent kind of cannabis had a specific effect in this region, and that the effect in this region was correlated with the subjective measures of how stoned people felt and how high they felt as well. So it seems like it's the disruption to this network caused by the cannabis in this region that's possibly driving those subjective effects. So kind of putting all this together, more in the context of drug responses rather than clinical effects, really. But you have a drug, you put it into a patient, it's in the blood, the drug diffuses to the tissue, engages the target. Maybe there's some kind of second messenger response, some more complex bit of neurochemistry happening, but that then leads to a kind of systems level tissue response, which has some kind of other physiological or behavioral response, and that hopefully leads to a good clinical outcome and happy patients. That's what we like. So kind of traditionally, that whole pathway has been hidden from us. You can shrink that black box a little bit by doing, pharmacokinetic studies of looking at how the drug behaves in the blood, or doing behavioral studies at that end. But it's really only in the last 20 years when we've been able to get kind of the whole view of that pathway using PET and using MRI, and ideally using the two in combination like this, because they provide complementary information in lots of ways. So moving on to the second part of the talk, when I'm going to try and talk about what applications this might have in psychiatry. Progress in neuroimaging has been pretty extraordinary over the last 40 years. So this on the left here, this is, as far as I can tell, this is the very first published brain image ever. So this was done by a guy called Terry Jones in New York in 1973. And Terry's still around. He works with us a little bit. He's an emeritus professor now. He works a little bit with us at Invicro still. But this was done with him in a PET scanner in New York, breathing in radioactive oxygen and taking images of his brain. This is one of the very first experimental PET scanners they had. So we've progressed from these rather nasty, fuzzy images up to the, very, very, very detailed maps of bits of the cortex. We know considerably more about how the brain works now than we did 40 years ago. I think, you can argue this, of course, but I think it's fair to say that clinical treatments and outcomes in psychiatry maybe have not progressed to the same extent. There's an interesting perspective on this from a guy called Tom Insel, who was the director of the American National Institute of Mental Health from 2002 to 2015. And he did an interview in 2017, so 2 years after he left. And it's worth quoting in full. So I spent 13 years at NIMH really pushing on the neuroscience and genetics of mental disorders. And when I look back on that, I realized that while I think I succeeded at getting lots of really cool papers published by cool scientists at fairly large costs, I think 20 billion, I don't think we moved the needle in reducing suicide, reducing hospitalizations, improving recovery for the tens of millions of people who have mental illness. Now, that's a pretty astonishing admission. So this guy had his fingers on the levers of power for this kind of stuff. He spent 13 years and $20 billion really pushing on neuroscience and genetics, and he thinks that he didn't make much difference in clinical terms. That's, it's unfortunate, but it's I think it's probably true. So what are the reasons for that? Well, there's lots of problems, but I'm going to highlight a couple. First of all, clinical heterogeneity, differences between patients. So imagine we have patient 1 presents with sleepiness, loss of appetite, low mood, feelings of worthlessness. Patient 2, in some ways, has the opposite. So insomnia, weight gain, anhedonia, anxiety. Do these 2 patients have the same underlying dysfunction? They might both end up with a diagnosis of major depression. Is it likely that they have the same underlying pathology? Maybe, maybe not. Kind of related problem is that you have one symptom and then multiple causes. So to take one of those symptoms from the examples above. Fatigue, okay, so fatigue might be caused by major depression. It might also be post-viral. That's a kind of big thing at the moment. Stress, you know, maybe they're pre-diabetic, maybe they're not sleeping well. You know, you could think of any other number of possible explanations, and some of those might be psychiatric in nature, some of them might be more organic. You know, it's difficult stuff. The other major problem is, I think, overlapping distributions. So say you do a hypothetical research project. You've got 100 depressed subjects and 100 healthy controls, and you find 10% less brain activity on average in the hippocampus of depressed subjects, let's say. So when you plot your data, your hippocampal brain activity, it's probably going to look something like this, where you've got a normal distribution of depressed patients and a normal distribution of controls, and they're a little bit different, but they overlap quite a lot. Excuse me. So any given patient in the study is most likely to be somewhere in the middle there. And this is the reason why I think, well, brain imaging is not currently useful for diagnosis, particularly of psychiatric conditions, and possibly it never will be, because you can do studies like this and you can identify differences in the brains of depressed patients or schizophrenics or OCD patients or whatever. But you're always looking at statistical effects in usually large groups of people, and always whatever brain feature that you might choose to study, you're always going to have at least a partially overlapping distribution. So it's a real challenge to move from these group level statistical effects to something that might end up being a reliable biomarker, essentially an imaging based biomarker, which you can apply to individuals as a diagnostic tool. And basically we're not there yet. There's a lot of work in that area, but we're not there yet. So can it actually be useful? I think it can. It can certainly be interesting. So, I mean, one topic that the neuroimaging world has really embraced is psychosis and schizophrenia. There's been thousands of studies on psychosis with lots of different effects found. So you can find that psychosis patients have decreased gray matter in various areas of the brain, particularly in the frontal lobes. You can find functional effects in schizophrenia, so disconnectivity between the thalamus and various other bits of the brain, particularly in the frontal lobes as well, and the cerebellum. A really actually interesting and useful kind of subset of the schizophrenia neuroimaging literature is about prodromal psychosis. So looking at people who are not clinically psychotic, but are at risk, either because they're in some high at-risk group, or maybe they're the first-degree relatives of schizophrenics or something like that, and trying to identify markers which might indicate likelihood of progression to first episode psychosis. So there's been quite a lot of work in this area, and some of it's fairly convincing. So you can find differences in the gray matter between people who convert to full-blown first episode psychosis and people who do not. This was another interesting study because they actually integrated PET and fMRI. So here we're looking at, on this plot, we're looking at an fMRI measure, the bold response during a working memory task, compared with a PET-derived measure from the striatum here, and the at-risk group in blue is differentiated quite neatly from the control group. So clearly, identifying people early on, identifying people who are at risk of psychosis, and possibly having some kind of intervention for them before they progress into full-blown clinical condition is clearly a good thing and something that's potentially useful. PET is also has been really useful in characterizing antipsychotics. There's a narrow kind of therapeutic window for most antipsychotics where you get a good clinical effect, but then as you up the dosage, you tend to get side effects. Most seriously, you get these extrapyramidal motor side effects, which are, quite distressing for the patients sometimes, are generally not good. And most antipsychotics are now, their therapeutic window is now pretty much defined in terms of D2 receptor occupancy measured by PET studies. So what you find is that above about 65%, you get a good clinical effect, but then above about 80% receptor occupancy, you start to see these extrapyramidal syndrome effects. So dosing regimes for antipsychotics are now optimized with regard to that kind of data and that kind of window. PET's also been really useful in characterizing the newer kind of atypical antipsychotics, things like clozapine. So clozapine is unusual because it seems to have clinical effects at lower D2 occupancy levels. So you can see here, this is the baseline scan. Haloperidol, like a classic antipsychotic, kills that signal. It's very competitive at the D2 receptors. Clozapine has less of an effect, so it's less selective for D2 receptors, has a more complex pharmacology involving D4 receptors. It's also less prone to developing these EPS side effects. So PET and antipsychotics has been extremely useful as well. Another example, more MRI-ish, is depression and the brain. So there were some early results which tended to highlight this result. So this is actually an FDG PET study from 97, which highlighted this brain region in depressed patients as being particularly important. So this is called the subgenual cingulate cortex. So the cingulate cortex runs through the middle of the brain, around the corpus callosum, and that bit that kind of tucks over in the medial frontal lobe is called the subgenual cingulate. And it turns out this has been a very important area, an important finding. There's been very many studies on this. This particular one, for instance, showed that the connectivity of the subgenual cingulate measured with fMRI was actually related to the duration of the current depressive episode. And what this has led to is actually, I think, probably the best example of a genuinely novel treatment which has arisen out of brain imaging results, and that's deep brain stimulation. So when you do deep brain stimulation, you implant electrodes in the brains of subjects, and if they're depressed, you generally implant them in this subgenual cingulate area. So you can see on these MRI images these dark lines here are the electrodes. And it does seem to work. It does seem to work at least some of the time. So this is a questionnaire measure of depression, clinical measure of depression. And you can see this, the patients had the implants done here. And you can see for a couple of these patients, it's worked very well. Their depression scores are way down. For a couple of others, there's a mild effect. And for a couple of others, it hasn't really worked at all. So this is a tricky one. It does seem to work at least some of the time for some patients. It's very hard to do proper clinical studies with this kind of treatment because how do you do a proper placebo-controlled version of this? Yeah, okay, you can do sham surgeries or implant non-functional electrodes, but is it really ethical to put people through a surgical procedure where they're not actually getting any benefit? Probably not. So that's tricky. It's very high cost. It's very invasive. Obviously, they have to have the electrodes implanted, and it also, only works some of the time. The last thing I'm going to talk about is depression and psychedelics. So this is some of my own work partly. So I work with David Nutt and another guy called Robin Carhart Harris at Imperial, who have done a lot of great work on psychedelics, usually with psilocybin, the active ingredient in magic mushrooms. So these are hallucinogenic agents, and they've been kind of really at the forefront of this movement in the last 10 or 15 years to kind of re-medicalize these compounds and use them for useful purposes. So this is a study that we did a few years ago. And these guys have developed this psychedelic assisted psychotherapy protocol, which is the treatment that they developed. So people take a dose of psilocybin and go through this long extended 4 or 5 hour therapy session, and we've also scanned them before and after this experience. And for these patients, these were all fairly severely depressed, quite treatment resistant patients. For some of these patients, well, for all of the patients, their depression scores dropped very noticeably after 1 week. For a few of them, they were still in remission at 9 months. A few others kind of gradually drifted back upwards again, but there were definitely long-term effects of this single dose of psilocybin in this therapy session. And what was interesting was we did a lot of fMRI work on these patients as well, and we were able to show that the connectivity of that kind of related area in the front there as well was related to their clinical response at 5 weeks. So the people that had the greatest change in the connectivity in that area also had the greatest clinical response in terms of being responders versus non-responders. If you've seen the news in the UK today, you may have seen another result from a similar study. So there was something published yesterday in the New England Journal of Medicine, which is their latest clinical trial on this. So in this one, they actually compared their psilocybin therapy with escitalopram, which is an SSRI. It's kind of the gold standard frontline treatment for depression. They found that psilocybin was somewhat superior to escitalopram on their main measure, but definitely superior to escitalopram in terms of increasing their WEMWeb score, which is a measure of well-being. And in fact, on every single measure that they employed in the study, psilocybin was superior to escitalopram. And we've also got brain imaging data from these subjects. So that wasn't in the paper that was published yesterday. That was just the clinical data. I've got a little sneak preview here. This is data that I've been working on, that I'm actually writing up. And what we see here is that we see a big reduction in responsiveness in the post-treatment scans when you compare psilocybin and escitalopram. And what we see here in response to emotional pictures is that you get a big drop in the post-treatment scan with escitalopram, and you don't get that same kind of drop with psilocybin. And this, we think, is related to the kind of emotional blunting that people often report when they're on standard SSRIs. And you don't seem to get that with psilocybin. You seem to get, in fact, almost an opening out and a re-engagement with your emotions and with the world. So it's at least as effective as escitalopram, possibly better, and you also don't get this emotional blunting side effect, which is nice. But this is unpublished data as yet. That's a little sneak preview. So I'm badly running out of time. I apologize. Just to wrap up, neuroimaging is good basic science, but translational results have so far been limited. This is still something that, people are very, very interested in, though. Of course, there's a lot of clinical research going on, a lot of clinicians involved in this kind of research. This is something that we want to make it work if we can. PET and MRI, to a lesser extent, do have a big role to play in drug development. There's lots of interesting developments on the horizon. So first of all, in terms of the research, we're on the threshold of this kind of era of bigger data sets, and all of the machine learning analysis methods, particularly deep learning networks, hold a lot of promise for this kind of thing. You know, if we can get these bigger data sets and start training these networks to pick up better differences, better results in the data, that might be helpful. There's also other approaches that might helpfully translate to the clinic that I haven't talked about, which are still in kind of early stages of development. So things like transcranial magnetic stimulation and neurofeedback may be good for things like anxiety or OCD, other conditions. And that's it. I know that was extremely quick and I covered a lot of stuff, but I'll be happy to take any questions if there's time.
Thanks, Matt. That was absolutely amazing. I was trying to tweet it as we were going through. I'm definitely going to watch it.
It's a bit fast,
again. But you covered so much. It was really, really helpful. We've got a huge number of really good questions, and we've only got 5 minutes, so we'll just have to see what we can do.
Okay.
There's one here. I understand task-based fMRI has variable reliability at an individual level for drug development. Could Matt comment on whether he agrees and why he thinks reliability at an individual level could be so? And then it stops. I think, oh, so variable. Well,
yeah, I mean, it's variability is a problem when you're doing human research. So, I mean, it's the kind of old saying, humans are very dirty test tubes, right? They're not just, they're just not reliable. And then you kind of add on to that the kind of various sources of noise that you get in an MRI scanner, which are, you know, considerable. That makes a difficult picture for reliability. So yeah, it's the same issue that you can look at group effects and see that generally things are very reliable in the group as a whole if you've got 20 or 30 people. But then say you do 2 sessions, you might get the same kind of group level effect. But then if you look at the individual results across the 2 sessions, some go up, some go down, some say it stay the same. I mean, that's just a general feature of clinical research, unfortunately. And it's a real challenge to move from those group level effects to reliable individual biomarkers. Yeah.
An interesting, I don't know if it's a question or a comment, but interesting here. How do you feel that changing the current ICD-10 classification to neuroscientific classification might help to diagnose and treat better? I mean, I think you were kind of alluding to that, weren't you? That our current classification system, it's based on groups of symptoms, isn't it? So it's not surprising if it doesn't actually match the underlying disease. But do you have any thoughts about that?
Well,
tricky one. Yeah,
very much not a clinician, but yeah, I mean, clearly the classification systems we have, the ICD and the DSM, they don't cleave nature at the joints neatly, right? But then what do you do with mental disorders? I mean, the symptoms are the disorder to an extent, at least. So you kind of have to classify on symptoms. Yeah. And there's some work which has shown that actually you get very, very similar brain regions involved in multiple different types of mental disorders. So looking across, you know, psychosis and anxiety disorders and mood disorders and so on, you get the same similar kind of brain regions. So maybe classifying on neuroscientific grounds is a bit of a non-starter as well.
Yeah.
Yeah.
I think a new classification system will emerge. I'm just hoping that I live long enough to see it. It will be one. Oh, there are so many questions flooding in, and they're all really good. Are there any studies or data from resting fMRI on ADHD?
Oh yes, lots. Yeah, so I have some friends who research that. There's a big research group at King's College looking at ADHD, both in adults and in kids and teenagers. I forget what the details of the studies show, but yes, there are certainly lots of studies on that. Yeah, good. And lots of studies looking at the effects of Ritalin and ADHD medication as well.
Lots of people saying how good the talk was.
Oh, thank you.
Yeah. Oh, here's an interesting one. What are your thoughts about combining imaging and clinical data using machine learning to predict outcomes? Wow.
Oh, yeah.
That would be nice.
Yeah.
That's my thoughts. That would be really good.
Well, yeah. Yeah, I mean, again, you kind
somebody's just popped a reference into the chat for something on that. Yeah.
Oh, great. Yeah, there is some work on that. So there's a guy called Mike Browning who works at Oxford, who's done some machine learning work with depression and SSRIs, trying to predict response and outcomes. Yeah.
There's just too many questions. Matt, you are on Twitter, aren't you?
Yes.
So,
please ask me anything on Twitter afterwards if you want. I'll try and respond to as many.
You better check my tweets and make sure I've got them all right in case I need to correct any of them. Sure. So it is 5 o'clock. Okay. I'm going to finish it there. Thanks, Matt. That was an absolutely brilliant talk and really interesting. So thank you so much.
For the opportunity you've letting me do it. It was really great. Very
kind of you to give up your time. And thanks to everybody who attended and everybody who watches this on catch up. And as I said at the beginning, keep an eye on the Neuroscience Project website, because we are going to, because this has been so popular, we are going to see if we can put on a bit of a longer event about imaging. So thank you, everybody, and have a lovely evening. Bye.
Bye.